welcome to the Equal Opportunities Committee, the third meeting of 2014. Can you please set any electronic devices to flight mode or off? I'd like to start with introductions. We are supported at table by the clerking and research staff, official reporters and broadcasting services, and around the room by the security office. I'm Margaret McCulloch, the committee's convener, and the members will now introduce themselves in turn, starting here on my right.
Good morning, John Finney, Highlands and Islands.
Alec Johnston, Member for North East Scotland.
Mark Obiagi, Deputy Convener, MSP for Edinburgh Central.
John Mason, MSP for Glasgow Shettleston.
Troy Mahon, MSP Central Scotland.
Christian Arad, MSP for North East Scotland.
Thank you very much. Today's first agenda is on witness expenses. In keeping with the usual practice, members are invited to delegate to me as convener responsibility for arranging for the SPCB to pay under Rule 12.4.3 any expenses of witnesses in our inquiries into female genital mutilation and fathers in parenting. Are we all agreed? Good, thank you. The second agenda is about taking business in private. You're asked to agree to take item 3 on your approach to the fathers in parenting inquiry in private at this and future meetings. Are we all agreed? Yes. Thank you very much. I'll now suspend the meeting and allow the room to clear before moving into private regarding item 3. Thank you. Good morning, everyone. The final agenda item today is an evidence session on female genital mutilation to help to inform our approach to a future inquiry. I'd like to welcome our witnesses round the table and just also to make you aware that the Parliament photographer will be here taking some photographs later on. Can I ask if you, and when you wish to speak during the discussion, could you indicate to either myself or my clerk on the left-hand side? And can I ask if you can actually begin for the witnesses to introduce yourself, and I'll ask yourself to start, please.
Okay. Good morning. My name is Fatou Balde. I work as a Programme Officer for Dignity Allied Research Forum. We work in the area of FGM, also educate professionals, and I am a survivor of FGM as well.
Thank you very much.
Good morning. I'm Anila Anwar, Head of Projects at Roshni. We're a charity that works with minority ethnic communities nationally, addressing child and adult protection issues.
Good morning, I'm Nina Murray. I'm the Women's Policy Development Officer at Scottish Refugee Council.
Good morning, I'm Mukami Makram. I have recently retired and a long-term campaigner against FGM. I'm currently involved with a number of African women's organisations and groups.
I'm Una O'Brien from the Institute of International Health and Development at Queen Margaret University. I've worked for many years in gender and health, and FGM has been an issue that comes up in that, and Fatou did her dissertation research on FGM with us at Queen Margaret University.
Thank you.
Good morning, I'm Jan MacLeod. I'm the manager at the Women's Support Project in Glasgow, and Women's Support is an organisation that works against violence against women, and our current work involves national capacity building for training and awareness raising round about violence.
Thank you.
Good morning. My name is Amy Edwards. I am the independent sexual violence advocate at Glasgow Rape Crisis, and I work with refugee and asylum-seeking women on any aspect of problems that they have.
Yeah.
Good morning, I'm Annie Lawson. I lived in East Africa for 13 years in a community where FGM was absolutely normal, or considered to be normal. When I came back to the UK, I worked with DARF, where Fatou works, doing the job that Fatou is doing at the moment, and I now volunteer for DARF, usually doing training sessions on FGM for professionals.
Thank you very much. Can I start by asking a question that's obviously been in the newspapers, just to establish what your views are on it, if it's true or not? The claim that Scotland is actually seen as a soft touch, and that people are travelling here for FGM on their children. Can you sort of comment on that and say, is that true? Anybody'd like to? Well, Jan.
I think quite several of us who are here today have discussed this, and it is raised quite often when I do awareness raising sessions with professionals about violence. And I've heard it as well from a small number of community activists that they've heard it in the community, but it's always been an anecdotal evidence, and an anecdotal level. And when I've asked workers who've raised it with me, say health visitors or midwives or whatever, it almost always stems back to an interview that was carried out by Newsnight in, I think it was July 2012, in which a young, I think she was a Somali woman, made a statement on camera to say that it was happening to girls in the north of Glasgow. It's been discussed by the Violence Against Women Partnership in Glasgow, and the police are part of that. But there's not been any hard evidence found. We've recently established a strategic group in Glasgow to look at FGM, and I think probably it would be fair to say that our view is that on one hand, it's hard to believe that it's happening here, and yet no child has ever presented at hospital or GP. But on the other hand, when you look at the numbers of families from communities that traditionally practice FGM, and when you look at the motivations and the pressures sometimes on parents to carry on the tradition, then it's hard to believe that it's not happening. So the answer is that we don't know. There's a gap in our knowledge there.
Would anybody else like to comment on that at all? Mukami?
Yes, I think the statement is alarming in many ways because people, especially the African women in the community, have complained that they are not even given a chance to know where this is happening. And if it is happening, those who know or witness that are actually aiding and abetting the practice if they do not report to the police or to any other authorities. And it seems to be a statement which is made in, as Jan said, because people want to either draw attention to the issue. But I think the important thing is, even when you look at the statistics, is to be clear about how we interpret the information we read, because not every woman from a practicing community has been mutilated or will go on to, or those who've been mutilated will go on to mutilate their daughters. And that is actually making a lot of people sort of withdraw from the debate because they feel, if I can give an example, when we used to complain about racism, if you said all white people are racist, the reaction was really negative. And the same way people are reacting in a negative way, which is not helpful for us activists who want to stop the practice. So I think anybody who makes a statement like that needs to be made brought to account, to explain and give evidence. When I've asked people, I've been working for the last 4 years on FGM and other harmful traditional practices. When I've asked people, they have always told me, I was told by somebody else who told somebody else who told somebody else. But we never get to the person who actually saw it happen. So it's not to say it's not happening, but I think it doesn't help to hype the whole situation and make it sound as if Scotland has become the place everybody's coming for FGM.
Anybody else like to comment? Yeah, Fatou.
Yes, regardless of people or the news saying that FGM is happening and we don't have the evidence for it, but we do know children are at risk. We do know women from practicing communities. Some women do still support the practice of FGM. And also research in other parts of the UK has indicated that many young girls themselves have had to undergo FGM either within the UK here or being taken out of the UK. That is evident. But we need to also consider that practicing communities really protect FGM. They do this, even though I am from a practicing community, but because I work in this, I do get emails from people telling me that I'm talking too much about, our personal things to other people. So people are very protective about the issue of FGM. And because of that, even if they know this issue is happening, it's very hard for someone from a practicing community to come out and speak up against their own people.
Yeah, thank you. Nina?
I would just agree with everything that's been said already, and I think one of the key issues is that we don't really know where communities are if they're practicing, and that's one of the reasons that we've sought some funding to carry out a bit of a scoping project around this, just to really understand the data that exists about where communities are and the levels of prevalence in countries of origin. But of course, a prevalence in a country of origin doesn't necessarily equate to prevalence in Scotland, so we need to be very careful with statistics that are out there in the public domain and understand them and think about, there could be within a country the prevalence may be very high, but certain groups of people from within that country might not be practicing. It tends to be quite located within particular ethnic groups or communities, and we've never, our casework teams that work with refugee and asylum seeking women, I've not heard of people, reporting instances of FGM being practiced here, but we have heard of instances of women in the asylum process who've left other parts of the UK because of pressures within larger communities in other parts of the UK and come to Scotland because perhaps they see the communities as being smaller and there being less pressure to practice FGM here. So we've almost seen a few cases of the opposite in Scotland.
Anybody else like to, any witnesses like to comment on that? No? Can I sort of also, leading on to that, can I ask the witnesses what your views are on the screening of girls at an early age in France? Would that be practical, or would that be helpful? Yes, Amy?
Definite view that that's not appropriate from an organisation that works with survivors of sexual violence. So I think the practice of screening young girls would be very invasive. It would also lead us to racial profiling and the potential that we would stigmatise certain groups. If a girl has been cut, then I think there will be a huge risk of re-traumatisation when they're examined, and if they haven't been cut, then we have to question why we're subjecting girls to such a invasive examination. So although on the counter side of that has led to more prosecutions, and maybe this is because of the deterrent effect. So a drop in cases, so there's prosecutions that's happening because people have been examined, but there's also maybe a deterrent effect, so that less people are doing it because they know that they might be examined. So I think there are arguments why people would want to go down that route, but I think the overall effect has to be questioned in terms of how it might affect the girls being examined. Also, we were having some discussion about to what age that would happen to, and one of the ages we had was they would be examined up to 6 years, and we know that the majority of girls are cut between the age of 5 to 12, with the highest majority being between 5 to 8. But there's nothing to say that the age of girls being cut wouldn't just then raise, so it's past the age of examination, and you know, we can only enforce it to a certain extent. So I think there's arguments for and against, but
can you sort of clarify why you think it would lead to sort of racial profiling? Because my understanding is in France all young girls would actually go through the screening process.
I think racial tensions in UK are already problematic, and I think if girls are to be examined and everyone is to be examined, then I think you'll have kickback from groups that don't deem themselves at risk, and why their daughters shouldn't undergo those examinations. So I think it would add to either further racial tensions, or it would lead to racial profiling and stereotypes of who's at risk.
Thank you. Makami, and then Jan and Nina. Anila.
Yes, I was recently speaking to a friend in France, and what she said is that we have to remember that we have different systems and different way of thinking, and we can't import something which perhaps has a long tradition and culture of the people, the openness and the fact that girls grow up, families expect that to happen. It's not just because of FGM, which is we are not used to that. There is also a whole, as Amy said, the question of how people would identify which girls should be screened. And that is why the feeling is, as it is at the moment, the assumption, because the figures show it happens mostly in Africa, they will be targeting the people who look African. To do that would also actually have some serious implications in that there's a chance that children who, for example, a white woman married to a man from a practicing community, who has, if you look at statistics, and we're going to look at children at risk because of the mother, that woman will never be, a child from a mother like that will never be considered to be at risk. But that child could be taken anywhere because the father may believe in the practice, and because we're focusing on the mother and the child, we could miss children at risk because of that. But I also came to this country when they were carrying out virginity tests at Heathrow, and I was made to stand in a queue, and it's the most embarrassing and a humiliating thing you can go through. This was way back. I don't think many people remember that. And I think if we're going to go down that route, we have to have so many safeguards, because we already feel at immigration airport, regardless of the fact we have equal opportunity and we should be checked at random numbers, and the number of times randomness lands on black people is amazing, and that will also mean the same thing will happen to, and I know some women who really kick hell because they have been fighting FGM for 30 years or more, to then find their children dragged through the system just because they come from that country or that community would be completely wrong. We have to find other ways, because at the same time, I would say yes if it meant protecting children, because I really would hate to think that we could ever find a child has been mutilated in Scotland. That is enough for me to say, yes, let's do screening. But I don't think at this moment we have enough measures in the system to protect, to make sure civil rights and dignity of people and liberties are protected through that process.
Thank you. Jan, please.
I think I would agree sort of largely with what Amy said. I mean, if it was going to be done at all, it would have to be done to every girl. And I can't see that the evidence justifies that, looking at the difficulties with it. And I think it has to be weighed up with the fact that we've had for a long time information about the prevalence of child sexual abuse, for example. The University of North London conducted a UK-wide study that found that 1 in 20 females had suffered a serious sexual abuse, such as a rape or forced masturbation. And there was no question then of every girl in the country being examined regularly to look for evidence of sexual abuse. So if you're not going to do it for a prevalence level like that, if you bring it in for FGM, where in a sense, I'm not saying it's less serious because the numbers are low, obviously it's very serious, but the numbers are much lower than 1 in 20. So I think we need to look for other ways of having safeguards. And I know that health services, I believe, are proposing that each child should be given a nominated health worker that would follow them through childhood. And I think there's opportunities there to look at how risk assessment for FGM can be strengthened through named workers, if you like, so there's a clear place where there's a responsibility for that, and for raising alerts if it doesn't come from elsewhere. I think that's something that has a lot of possibilities for future safeguarding of children.
Thank you. Anila, please.
Yeah, I would largely agree again with a lot of what's been said, and my concern would be, you know, we need to use more culturally affirmative approaches, not approaches that are going to stigmatise a community that are already putting up walls around this issue. I don't think it's going to be helpful. But also in terms of screening, it almost seems to me a little bit to be the end of the process, where we're screening to then try and prosecute, whereas we should be concentrating at the beginning, trying to prevent it. And as Jan's saying, looking at, you know, processes and procedures we can put into place to try and stop it from happening in the first place, whether it be a named health professional, whether it be more training and awareness raising for frontline staff in the health services, teachers in schools, who can spot signs, spot young people, girls who are at risk, and try and stop it happening before it gets to that stage. And I think that's where the focus really needs to be. And over and above that, we're not going to stop FGM or break this cycle until we create attitudinal change within communities. So I think there needs to be a lot of sustainable effort put into community engagement programmes, and without that we're not going to get anywhere, without engaging communities, men, women and girls on it, and empowering young girls and women to be able to make their own choices while staying safe. I think that's really key to tackling FGM in Scotland.
Thank you very much. Could I bring Alison in? Alison, welcome to the committee. Could you introduce yourself first, please, and then if you could answer our question.
Yes, my name is Alison Wales. I'm Policy and Information Officer at NSPCC Scotland. I really just wanted to make a point regarding what Jan was saying, and NSPCC would, you know, agree very strongly with what everybody really so far has said today, especially around prevention and the focus being on prevention of FGM. And Jan talked about the named person, and while NSPCC have been really supportive of the named person in principle, it's just to draw a note of caution around that, because I think everyone is really aware of the lack of resources for named person, and especially if we're looking at, for example, health visitors' caseloads. We know that there are health visitors with enormous caseloads, so the idea of really, you know, without a lot more resources in this area, that being a kind of, you know, sufficient preventative tool, that just to say that that would really need looked at. However, in theory, an attached named person who would be following the child from birth to school age, and there's also the same implications around named person for schools, where, you know, the teacher who's the named person may also be very under-resourced in relation to what else they're dealing with, especially where that's the head teacher or deputy head.
Thank you. Una?
I would just echo what everyone else has said, but I think in terms of prevention, it seems to me there's some really basic, obvious things that are quite simple to start implementing. So Fatu's research of women going through maternity services, as soon as the child was born, they get targeted around, are you going to do FGM on this child within, I think Fatu can clarify, but within hours of giving birth, you're being kind of attacked by somebody saying, are you going to carry out FGM on your child? And that could be a much more positive and engaging kind of experience. But I think we had 2 dissertations on FGM carried out last year at master's level, and both highlighted such a lack of training and awareness in mainstream NHS professionals. I think that is a kind of no-brainer in a way to start at that level.
Thank you very much. We'll move on a bit now, and we'll move on to sort of the collection of data and information, and I'll pass you over to Marco Biaggi, who's going to ask you a few questions now. Thanks.
Yeah, I mean, we've heard about this being possibly anecdotal. I wonder, Dr. O'Brien, you might be in a good position to say if other countries have achieved an effective data collection, because it seems to me there would be real problems with that. Yes,
I mean, Fatu did collected some of the latest literature. I think Switzerland was one of the places that has recently carried out a good piece of work and have done some quite in-depth...
countries where they have got this in-depth research, how do they gather it? You know, the only statistics I've seen are estimates based on the number of people that come from practicing communities. There must be a better way than that.
It's very hard to know the exact figures. That's why in most countries it is mainly estimations. They look at data from census and estimate from there among the number of migrants. And I believe we would still have the same problem in Scotland, but what's most important is that we do know there is a huge amount of African women living in Scotland from practicing communities. So that indicates that there are a lot of women from practicing communities who might had FGM whilst back home. Therefore, their kids are at risk. I come from a practicing community. I have not even have a daughter yet, but I know the amount of pressure that I get now. I'm getting questions about what would you do if you have your daughter from my parents, from my mother-in-law. So imagine the women who already have daughters. So it is evident that there are children here who are at risk. The numbers are here, but it will be very hard to get the exact figures.
Estimate the number that are at risk reasonably well, but we don't know how many of them, and we almost can't know how many of them are undergoing the practice.
And then Una.
Various attempts to estimate prevalence and risk in EU countries, and there was a recent report by the European Institute for Gender Equality that has collated all the different studies that have been done across the EU and Croatia. But the only studies that have been done for the UK are on England and Wales, so nobody's really beyond having a look at basic census data, taken that any further to estimate risk or prevalence in Scotland. There's quite a useful narrative in this report about the pros and cons of different methods of gathering data, and the census is an obvious place to start, and we've got new census data that we can look at as a kind of indication of where populations might be, but then beyond that, we need to look at kind of administrative records, such as health records or child protection records, international protection, Home Office type records. But with each of those, there are their own issues, because it all depends on how well data is being recorded, whether there are particular kind of codes and methods for recording FGM. So this is part of the reason why we're going to work with the London School of Hygiene and Tropical Medicine to carry out a short scoping project that we've received funding from the Scottish Government for. So we're hoping to be able to, in 6 months, 7 months' time, provide a bit more of an evidenced estimate of prevalence and risk in Scotland. But for so many different reasons, it will only ever be an estimate. But at least that will be a baseline from which to start on, and it may indicate areas where further research would be useful and more in depth with academics like yourselves.
Amy, would you like to come in?
I was just in the answer to the question of can we ever know? I think unless we go down the route, like France, for example, which we've already discussed here, to echo what Nina's saying, I don't think we can ever know for sure. And I think the more that we increase the stigma around it, the less access we're going to have to understanding the prevalence rate. But I think what we can be sure is that if we know it's happening possibly at all through anecdotal evidence, then we have a duty to act on it and start putting in place things that will counteract.
Makami?
I think it's, as it has been said, it's really difficult to get accurate numbers, even in the countries where the prevalence has been falling. And this is because FGM is not something people will easily put their hands up and say it has happened to them or they are likely to do it. But I think we need to also think about what we want data for, because if it is about prevention, we should be looking at prevention for all children, not just the way sometimes people use data in that they identify the largest community that practices, and then they forget the other people in the other community. For example, now the focus on Somalis and refugees means everybody else can go free, because then nobody is paying any attention. So we need to look at other ways of engaging with people. We do need statistics because they help planning of services. And I think somebody said the resources are not adequate. But they have to be statistics which also are taking into account that women, we have said, that have come from practicing communities, are coming from countries where the rate has been falling. Burkina Faso is one of the countries in Africa which has been recorded that has had dramatic fall. Kenya is another one. When I was growing up there, it was something like maybe 90% is down to something maybe between 25 and 30. So that means the numbers, then we just look at them as they appear. We could actually, going back, getting the message wrong and stigmatizing people all the more. And it's really difficult even now to try to encourage people. I emailed a few people to say I'm coming here and to get feedback. And some of them said, well, everybody talks about it. What do we have to say? They don't include us. We just feel like we are criminals because this is another target towards Africans. And I keep telling people, no, it's not about that. But if that is how we all know that perceptions are more important than facts when you're dealing with the communities, because they decide by the sort of the rumors that are going around. So we need to look at statistics in a way that helps the community understand this is about supporting you and providing better services. It's not about finding out which one of you is doing it and criminalizing them.
Before I move on, can I ask you why the numbers have actually reduced in places like Kenya?
Because of the campaigns, where this has happened, there are a number of factors which are common. First of all, it has come from the people themselves. So their external people support what the women are doing there. You also have a situation like where leadership Like in Burkina Faso, Thomas Sankara, he was assassinated. When he became the president, he made it clear that he wanted to eradicate all harmful traditional practice, and he encouraged women within a very male-dominated community to reject those practices. Then the laws were put in place that protected and those at risk and supported the women and the children. And that empowerment process, again involving the whole community, and then it turns around. The FGM stops being the desirable thing for people. People start looking at other ways of women getting income other than being married. The reasons for FGM become less important than other factors. It's a gradual process. It's taken, I'm more than 50 years old. It's taken that long for Kenyan numbers to go down. But in the 21st century, we can move things a bit faster because we have more knowledge, more information, and more people against FGM than ever before. But without involving those communities and engaging them and letting them lead the way, we are going to have the same problem over and over because they just vote with their feet, and we are left as activists talking to ourselves.
Una?
I also wanted to say I think that the numbers is really important, but there's many other issues. I mean, if there's one child where it's going to happen to, that still matters. But I think to get the kind of the complexity of the issues around it, it needs some really innovative research methods as well. And I think the kind of research that Fatou did with her own community, where she can access people and they can trust her, is very important as part of the picture. So one thing is getting the numbers, but I don't think we're ever going to get the accurate numbers. And what are we going to do when we get them anyhow? I mean, that's just to show that there are people in Scotland. We know that anyway. So I think it's about a multifaceted approach to data collection, really, and employing lots of innovative ways of carrying out research.
Okay, I've got another 3 people that want to come in on this. So, Fatou?
Yes, I'm just happy that Mukami mentioned some of the countries that prevalence rate has dropped, but having said that, there's still many other countries where FGM is still widely practiced. I come from a country where it is still very common. You go in the summer, it's like a birthday party. Everybody is celebrating it. It's not hidden. So in countries like that, if a person who comes from that country, you do know that they're still at very high risk of their children having FGM. And regarding numbers, for instance, in England, what they do now when women are pregnant and they ask questions, which is now adopted in Scotland as well, if they find out you have had FGM, you're monitored, and if you have a daughter, social services involved, and they monitor the child as she grows up. I have a niece, and I know my sister gets visits still because she had FGM, and my niece is about 8 now, but she still get monitored to make sure that she's not taken back home to get FGM done, and they also make her aware of the law and everything. And I think strategies like that would get the women involved, like practicing communities involved. And the other thing is most people from practicing community don't see FGM as illegal, or they don't even know it is illegal. So it is very important to educate practicing communities about the law on FGM as well. So.
Okay, thank you. And yeah.
How do they ensure that monitoring relationship is sensitive?
I think it all goes back to training professionals. Before they are actually sent out to do the work, they get proper training. I know forward does a lot of training with healthcare professionals, and in Scotland that's what we do at DAF. We work with healthcare professionals, social workers, teachers, to train them so they know the signs to recognize when a child is at risk and stuff.
Okay, thank you. I've got 3 people still want to come in. I've got Jan, Nina and Alison. Jan.
Excuse me. Just in terms of the numbers, the prevalence, I think it's really important to highlight that it's constantly shifting. And in terms of training professionals, it is quite a lot of information for people to retain, given that the numbers that they see might be low. But I have found that there is a general ignorance about the fact when I've done awareness work, when you say to people, what countries do you associate with FGM, they almost always say Somalia first, which is not unreasonable because the rates are so very high in Somalia. And then which other countries, they commonly say Kenya or Gambia. Now, they're not necessarily the next highest on the list. There's a real lack of awareness about FGM in Arabic countries. People are very surprised at the high rates in Egypt. They're even more surprised to find out about the high percentage of FGM carried out in Egypt under hospital conditions. So it is not poor or uneducated people necessarily. You're including professionals who obviously travel in a different way from an asylum seeker or a refugee would come into the country. So people don't realise that professionals would be less likely to be alerted, I think. And personally, I didn't realise there was such high rates in Iraqi Kurdistan until very recently. And we have quite numbers of people from that region now, and I've also been told that it does happen in some parts of Eastern Europe and Georgia. So it's a constant sort of learning curve really for everybody, and that makes it a difficult thing to sort of embed in professionals' knowledge, and really highlights the absolute importance of changing attitudes in community, because it's a community that's going to be the first point of both information and alert to safeguard girls at risk, and also to give information to women about health services. And the other thing I think is like an awareness that in terms of things like the signs and that, and awareness is that there are some indications that people are moving away from type 3 FGM to type 1 FGM, which has a less serious physical and sort of lasting health impact and would be much less noticeable. For example, I would imagine if a girl was taken away for a few weeks and brought back, the recovery is going to be much quicker. But the human rights issue, and to a large extent, I think the trauma and the impact on your sexuality and sexual relationships remains. So it's a very difficult issue to say that there's just like, you know, one or two actions that will solve it.
Thank you. Nina and then Alison.
I was just going to go back to what Una and others were saying about innovative research methods and looking at community engagement really as a key area in terms of prevention. I think we're hoping to work, well, we will be working closely with our women's community development worker to kind of look at best practice approaches to prevention work in other parts of the UK and Europe as part of our project. And I think that really has to be key throughout any work around FGM. And as Makami was saying as well, you know, kind of community engagement is really, really key, and long-term investment in community engagement. That kind of work is really resource intensive. Our project at Scottish Refugee Council works closely with a refugee-led group of refugee women, and we know from experience that it takes time to support groups to work through issues, and it takes a lot of investment, it takes money. So I think something that will be really key throughout this work will be investment in community development and community engagement in Scotland, which is an area that has suffered over the last few years in terms of cuts.
Thank you. We've got Alison, then Annie.
Yeah, I just wanted to really welcome again what various people have been saying, especially Makami, when she was talking about an approach that had really been based on encouraging women and girls to reject this practice and moving on from that, and hopefully men as well, encouraging you know, men to reject a practice. And I wanted to really draw attention to a couple of things. There's currently a violence against women strategy being developed at the moment. As far as I'm aware, it was supposed to be out for consultation, but so far hasn't appeared. So I guess what that strategy is going to say about FGM and how it's going to be embedded within that strategy on violence against women in general. And again, as Makami was saying, you know, for the communities to really lead on the writing of that within the strategy in terms of how it needs kind of tackled. There's also the National Child Protection Guidance in Scotland, which has recently been undergoing a process of being refreshed, and there is a fairly comprehensive section, albeit incredibly short, FGM with no real kind of background information. But in terms of being recognised as a significant child protection risk, you know, it is there. So there are certain things that are already in place, although a huge amount more needs to be done. So what these two particular documents are going to say about FGM at a strategic level is incredibly important. And the other thing I wanted to say was regarding sort of community engagement and community awareness raising, was really just to raise awareness that NSPCC has a national helpline on female genital mutilation, which is a very recent aspect to the National Child Protection Helpline that NSPCC runs. And it's obviously incredibly early days in Scotland. There has been no awareness raising so far. It's only been around for 6 months. And that was based on freedom of information requests within England and Wales that showed a large number of women presenting at specialist clinics. But as I say, early days in Scotland in terms of raising awareness of this helpline, but UK-wide, there have been 152 contacts to the helpline since it was opened in June last year. And I think around half of these are from professionals and the public, and about maybe 70 of them have resulted in referrals.
Thank you very much. We're now moving on to Annie, and then we've got Jan and Anila.
Okay, so this is going to be a slight ramble here. I do apologise. There are a couple of points. I had a friend come to visit me a couple of years ago at my house, and she brought another friend with her who is British, but obviously they came from another country decades ago. And I was just talking a little bit about FGM, and she said to me, 100% of our community have it done here in the UK and always have. So it's not just people who we see as being relatively recent immigrants. There is an embedded system. I couldn't tell you what level it is, but for her it seemed normal, and it was being done in the UK. So we have to be a little bit careful in pinning it on recent immigrants. It's not. It has been here, but it hasn't just not been around. I think the most important thing in the whole of this discussion is that we have the right ethos in the approach, and that very responsible press releases, everything that we say has got to be done, because I think a lot of what has been said, people are feeling stigmatised, and that there's a hostility, because when people report things in the press want to make a big splash. They want it to be a big story, and that's really not the right approach. And so responsibility from the press would be a massive thing, and how we speak about it, we have to make sure that our attitudes are right, because the words that come out of our mouths are not just what comes across, it's the whole attitude. And if we are, there seem to be two approaches that are being looked at. There's the legal approach where we prosecute, and the other one trying to get the community on board. And we haven't really, I feel, come up with a good strategy. It seems to kind of sway one way or the other. One approach looks a little too gentle and a bit wishy-washy, and the other one is very legalistic and will probably just drive people underground. And I'm not sure we've quite got the right approach yet, so that would be something I think that would be worth looking at. And I think Mukami made a very good point about how the French system for monitoring numbers does not apply in this country, because it's not been embedded in our system. Remember that when people come into this country, our legal system is completely alien, and how we approach things will grate on their culture. So there's quite a lot of work that needs to be done, and whilst we're having a very sensible discussion about it all, I still feel it's not really been we haven't come up with the right approach yet. So just those are the few things that came to my mind. And I suppose a plea to everyone, let's at least try and have the right heart, because what we want is for women and girls not to have this happen. How can we make that happen?
Thanks. We do have some other speakers, but we've got other topics we'd like to actually discuss. So if you're okay for us to move on, we're going to look at the healthcare issues, and my colleague Christian Allard has got a few questions he may like to ask.
Thanks very much, Convener. Yes, we talked about healthcare already. I think some of you have already touched into the point. But I wanted to generally speak about the experience of female genital mutilation victims and the treatment of the Scottish healthcare system. And particularly, I want to know if there are existing policies and protocols, and if they are they sensitive enough and are they fit for purpose? And what is being done to raise awareness and sensitivity to the issue to the medical profession? We talked about training a little bit, and I want to know if it's something which is done across Scotland, or is it done just in some areas?
Jan first, and then Makami.
Part of the work that we do, which is actually funded through the Scottish Government Violence Against Women unit, and just as a point of information, the strategy's just come out for consultation, and there's an opportunity to comment on it before the end of February. And so anyway, so as part of the funding that we have is about training, and recently I did a scoping exercise with the Violence Against Women partnerships. I'm sure some of you will be aware that throughout Scotland there is a sort of framework of for strategic work on violence against women, and most local authority areas have some sort of multi-agency partnership or forum, and very often they oversee training. And what I've found is that whilst there was quite a flurry of activity and awareness raising around about 2005-2006, when the legislation came in, that very little of that has been maintained and delivered in a consistent fashion. We have had and still have a number of areas calling on people like Fatu and her colleagues at DAR, Shakti Women's Aid, Sahelia, and others who are involved in training and awareness work on these issues. But they tend to be one-off events. And what we're seriously lacking is systematic training for key staff, because with the best will in the world, you can do training for workers. You'd be lucky if you get more than 2 hours on an issue like FGM, with all the pressures of vacancies and funding cutbacks. It's particularly difficult with health staff, where you have to backfill the posts, to run the clinics and so on. So you're not going to get a deep understanding of FGM in that little slot. So you need to look at key members of staff. And just recently, Health, because of the media coverage and interest in FGM, they're looking again at their training and looking at key places like smear testing clinics, well women clinics, obviously maternity services. In Glasgow, the Health Board have got a specialist post within maternity. And I mean, really, all roads lead to that one woman if you ask any health question about FGM. And so I think we need to look, especially in the Central Belt and the cities where we've got significant numbers of, as far as we know, of people from FGM practicing communities. I think we need to look at a sort of system of having health champions, so you'd have somebody within mental health who had raised knowledge about FGM, somebody within child protection, somebody within maternity, so that they can be sort of go-to person and inform the service. Not that they do all the work, but that they are there to inform the work. So at the moment, there's a lack of consistent training. And that's something that within our funding this year we're going to look at developing training resources, including a short Scottish DVD that will include information on the Scottish legal and child protection systems. We don't have anything like that to resource training, and also looking at a risk assessment for child protection. This funding's just been recently awarded, so I'll be coming to speak to some of the people around the table about it.
Thank you very much. I have another 5 speakers that would like to sort of contribute, and we've got another couple of areas that we'd like to cover, so can I ask everyone if they can be as concise as possible so we can cover the whole range of speakers and subjects. The next one I've got is Makami, followed by Fatu.
I think health is a very important area to look at, because most women, in fact all women who have children will at one time or other be in contact with health professionals. So that could be the starting point of first of all, support for those who have been mutilated, and also engaging with them so that their children are protected. But there have been guidelines. There are guidelines, NHS has guidelines on FGM. Midwives also have guidelines. Now the question is, why is it so difficult to implement those guidelines? And also, why is it so difficult to share information? Because that's one of the biggest problems I understand from professionals, that everybody keeps information to themselves. Communities do not allow, or organizations that work with communities, some of them do not allow health professionals or the police or other people to speak to the groups, which means there's no exchange of information. And if we look at lessons learned from other areas where communities and professionals and all stakeholders are involved, so it's not just about taking people to court, it's about preventing the need to take people to court. I think that's where the focus should be in working with not just the health professionals, but everybody else who is involved in the life of a child or women. And that could be, we're talking about schools as well, and the police, social workers. If we could track, we could have a pathway of tracking a child, as Fatu was saying, but perhaps not the same way, where from midwife to the health visitor to the nursery school, there's proper information, which is again about the child protection, because the guidelines are already there, which explain clearly what we should be doing. We might begin to see, to be a little bit confident that we are doing the right thing, or we're going in the right direction. Having said that, we know FGM is such a complex, and the diversity of opinion even around here is because of the diversity of the communities where it is practiced, of the professionals' view of what we should be doing. So to come back to a more concerted way, and the training, for example, is so haphazard. Everybody has their own way of training. You can go to the internet now and download a whole training package. But the training that you need for the police may not be the same as you need for social workers or you need for midwives. So there has to be a targeted way so that the training is useful, not just one fits all, because it doesn't work that way.
Thank you very much. Fatu, please.
Thank you. I think one thing we've all agreed on is that it is very hard to identify women who have undergone FGM. And I believe one of the best way to find out about this issue is through healthcare when women are pregnant, because then eventually this will come out. The woman has had FGM. And during my research, my finding showed was that the issue of FGM was not discussed properly between healthcare professionals and practicing communities. All the women I interviewed in my research were not asked about FGM during antenatal care, and some of these women have had FGM type 3, and this wasn't known until at labor if they didn't speak out about it. So it is very important that women are asked about FGM during antenatal care, and I also believe that this is a period where we can monitor, because at this point when a woman gives birth to a daughter and she's had FGM, we can monitor that. They can be educated about the law, they would know that it's illegal to perform FGM on the child, and also the child can be monitored. And from that as well, healthcare professionals can keep numbers record and share this information. My colleague Katie also did her research on the same area, and she found that healthcare professionals were too afraid to ask women because they are worried of offending them or being insensitive or something like that. So they were avoiding the question of FGM. And another thing is the terminology. Everyone in here, we're using the term FGM, but in practice in communities, if they don't work in this area, they don't know what FGM means. So if I didn't know what FGM meant and I went to the midwife and I'm asked, have you had FGM? I'm going to say no, because I don't know what it means. So women need to be asked the right questions, which again leads us back to training. If professionals know what terms to use and how to approach these women, then they would ask the right questions. I'm sure they all want to ask the questions, but then there are other complications why they're not asking the questions, basically.
Okay. Can I just ask, on the back of that statement, it says that raise awareness with the woman at the sort of antenatal stage and keep her informed. But if she knows that is illegal, how do you combat the pressures from within the family circle to proceed with that? It's okay giving information out there and saying it's wrong, but what support is there for the women that decide, I don't want this done to my children? Where do they go for help?
Well, that is lacking. Mm-hmm. They don't get that support. But what other countries have done, for instance, Holland, because mainly FGM is more practiced when they go back home with their kids. They have a certificate, which is also being implemented now in England, I understand. When they're going back home with their daughters, they carry this certificate with them, and when they go, they will show it to their families that I'm giving this document for my daughter's safety, and if she undergoes FGM, I go back, I'll end up in prison. And most of us Africans here, we support our families back home, and you make that clear. If anything happens to my daughter, if I go back home, I'll end up in prison, and you won't be getting any money from me. Mm-hmm. That seems to be working, so, you know.
I don't know what to say about that, actually. I'll pass on quickly to Anila.
Yeah, well, to be honest, to kind of echo some of Fatu's points and what Jan was saying as well, just on that point there, I think far too much of the onus is put on girls and women to report FGM, and I don't think that's acceptable. The onus needs to be put on healthcare professionals, teachers, those frontline staff that are in the lives of girls and women. And I think we need to be clear on that. Community engagement and change from within the community is absolutely key. But in terms of reporting, because of all of the difficulties, because of the potential consequences of going against your family, and we know how extreme that those can be, I think it's really important that the onus is put on those healthcare professionals and teachers. And the training has been inconsistent and ad hoc. And we've been delivering training on FGM for quite a while, face-to-face sessions with local authorities on a multi-agency basis as well, teachers, healthcare professionals, police. But the problem with budgetary constraints is that they can't always train as many people as they want. Staff have limited time. They can't go away for face-to-face sessions. So we've alternatively developed e-learning programmes, and we have one just now that covers child protection issues specific to minority ethnic communities, and it includes a section on FGM. And we found for that basic awareness raising level across the board with staff, it has really helped increase awareness. And we're currently working on a FGM-specific e-learning programme at the moment. We'll go into more detail and think will help with some of those targeted and identified staff, as Jan was saying, perhaps health champions as well, which could then be followed up with face-to-face sessions. So I think essentially what I'm saying is there needs to be a consistent approach. It can't be that I'm going to train someone and I'm saying something and then someone else is going to train them and telling them something contradictory. It needs to be consistent, and I think e-learning is a form, if we work on a partnership basis, a way of doing that, and it's also sustainable because people can continue to access it. So there does really need to be something, I think, on a national level that people can access to find out information about FGM.
Okay, thank you. Una, but could you also maybe include, if you can, everybody's been talking about health visitors, the women and the children, but what's also been done to actually raise awareness within the male community within the...
Yeah, I mean, I don't know what's been done within the male community, but I think it's absolutely essential, and I think there could be some real support and allies there. Because I think in countries where numbers have come down, and I know this is an academic, it's not that I've been involved in it, although I have had a campaigning background in gender issues. But you've got a kind of duality of the legal system. All governments have signed up to international human rights, instruments, and then you've got grassroots as well. I think one doesn't work without the other, and you've got to have both working together. But I think the other group of people who are left out of this is actually women who've experienced it themselves, because the first time I taught about FGM in a class of anthropology was in the 80s. And I remember realising some of these people are from practising communities. I can't teach this as some abstract thing. And over those years, since then, many years, I've had many people come up to me and say, oh, that is what happened to me. And I didn't know that's what it was. I didn't know that's what it's called. I didn't know this is how it is. And my colleagues have had that experience as well. So I think the level, what Fatu's saying, if people see that word FGM, they won't recognise that. I mean, there is a whole understanding that's got to happen as well. But working with men, I don't think much of it's been done. Look at other people, and I think really important.
Okay, Amy, and then Alison, and then we'll move on to the next section. And we'll go back to Christian.
Just to go back to what Fatu was saying, really, with the... I think the policies are in place, and I think there are guidelines, but then translating that to the communities... recently spent time in maternity care with a woman who had undergone FGM, and although the knowledge was there from all the healthcare professionals, the translation of that knowledge to the woman who needed to get it was lacking. And so I think we do need a consistent approach to training on FGM, but there's also a huge amount of training that needs to be done on cross-cultural communication generally, and approaching this nervousness that healthcare workers have on bringing up these issues, which is, of course, a really resource-heavy approach. But if we want to see the training actually going to use rather than just staying with the person who's been trained, then I think there's general work that we need to do on terminology use and how to approach women.
Thank you. We've got Alison next. And Alison, could you include in your sort of information what terms do women actually, or do the community recognise other than FGM as well, please? And then we're over to Christian.
Yeah, sorry, I can't actually talk about that because I don't have really specific information from the helpline as yet. All I have managed to kind of obtain so far is really just basic information about the numbers who are contacting the helpline and from what groups they are drawn, professionals, public, etc., and what groups within professionals. However, I know that the data is looked at on a very regular basis, and any opportunities to explore that data would be extremely welcome. Hopefully, doing that in conjunction with colleagues that know far more about this than us, because that really is, as I say, early days in Scotland, and this is not where NSPCC Scotland's expertise is. But I mean, the points I wanted to make were two, actually, and sorry to go back to perhaps issues that have already been covered. I think, although there is policy that dictates what should be happening in relation to children, National Child Protection Guidance, the guidelines are often not in place in some instances, and that's what a BBC Scotland investigation in 2013 uncovered, that across the 32 local authorities, less than a third had specific local guidelines on FGM. So, and also in relation to that point, less than 10 cases had been referred to social work. So clearly, around the issue of information sharing, again, to go back to what is being passed between professionals and the understanding that professionals have when they're working together on this issue in conjunction with children and families. My understanding from working closely with practitioners in the NSPCC and in other areas such as young people's sexual health services, which we have close working relationships given the nature of contacts to Childline, is that the biggest thing that impacts on information sharing is a hugely trusting relationship between professionals, and clearly, the amount of work that needs continually done there for people to have close working relationships. And I think what Jan was saying earlier about perhaps champions for FGM and people who were really able to go out and develop these very trusting relationships and, you know, expertise on the issue. And the only other thing I wanted to say was in relation to having an understanding about what is happening. And again, sorry to, I know you asked for the emphasis maybe to be taken off children and women and to be looking at men, for example, or the wider community. But in relation to what children, the understanding that children have regarding what's happening to them, and I'm relating this firmly to, you know, sexual abuse, which obviously is another issue that impacts very, very deeply on children, but which they may, for quite a long time, not understand as being something that is unusual or that should not be happening to them because of the way it might be happening within sort of family, loving family or close, you know, close friends kind of relationships. So certainly what Childline hears from children about sexual abuse is that, you know, it can be a slow dawning on them process that what is happening is profoundly wrong. I guess the role of education in embedding children's rights within education from the word go, in terms of children having a right to be protected from violence, children having a right to be protected from harm, is totally crucial in a global sense on getting messages across to children. But of course, that is not to put the onus on children as the people who need to, you know, feel responsible for coming forward, because children can be full of incredibly complex emotions, including guilt about what's happened to them, and torn between loving their family and actually hating people for what's happened to them.
Thank you. Can I pass you on to Christian now to carry on?
Thanks very much, Convener. Just two quick questions, so I hope we're going to get two quick answers because we haven't got so much time. Just talking about the language, we heard that people are afraid in the health services. What kind of question, what kind of language using? The community, we're not sure what language we are using. To tell you the truth, I didn't know what language to use. Is FMG the right way to talk about what we heard this morning, the issues, the practice, or should we say female genital mutilation, or should we maybe define another language? And that's one question. The second question is, there's a call by campaigners that I don't know if anybody around the table agree that female genital mutilation should be treated as child abuse.
Makami.
I think the first question is, I'll answer your question last. Yes, it's child abuse because children do not make a choice it's imposed on them, and it's very brutal, and the consequences are long-term, and it cannot be reversed. In terms of the language, which the communities, depending again on where people come from and the language they use terms like cutting, circumcision, party, going to a party, cleansing, growing up. It's all, but you don't, the term female genital mutilation is actually used by activists, is also agreed by WHO and UN as a term to use, and it was agreed to show the brutality of the act rather than it's not a rite of passage or something nice as is presented by the community. There is divided opinion because some people say when we use it, we are pushing people underground and they don't want to, because it's too emotive, they don't want to engage with us. But at the same time, when they also say it's a brutal experience they go through. So we could have some organization and some groups say, among the professionals, you can continue using FGM, but if you're going to engage with the communities, you need to understand the community, to know the language they use and how they feel about it. Because it's about also shame and and embarrassment that they are having to defend a practice they don't like. But they're only defending it because they feel they are under attack from the outside. So we need to bring them on board so we are part of they are not, it's not them and us. It's one group of people challenging FGM. on men, I have spoken to men and to faith leaders, and my disappointment is they all tend to blame women. They tell me, you do it to yourselves. You're the ones who carry it out. Although we know some medics are men and they carry it out, or rather we have read that some in clinical settings men carry it out. But we need to understand this in a wider context of violence against women. The factors that drive women to do things that they think men like, or rather that will give them status in the community, that will make their girls marriageable, will increase the dowry, bride price. Bride price, because there are so many things associated to it. And bride price is really selling your daughter to the highest bidder. No, it's not really a love relationship. And we understand that context, and we challenge that in terms of gender equality. Then women will start feeling included, because the first question some women tell me when I'm speaking to them is that, how dare you speak to us like this? Well, white women can do whatever they want, and they have all sorts of cosmetic operations on their genitals, and it's okay. And they say there's double standards. So we need to understand that so that we can approach it in a way that we are not saying that some practices are okay if they're practiced by one section of the community. We are saying they are all bad. Some may choose to do it, but children don't choose to do it. So we need to do it from the position that we are violating their rights. We also need to break the silence, because there seems to be a taboo about talking about FGM. And that is also because the communities we come from do not discuss sex openly. It's not, you don't discuss sex or genitalia openly with people, so it becomes an issue when you're going to talk about health.
Thank you. We'll move on. Sorry.
I should have maybe been more precise on that particular term. It's using FGM as opposed to using female genital mutilation. FGM seems to be, an acronym used around there, which doesn't mean nothing for most people, even for the communities. But
my computer keeps refusing to send emails when I put the full, and I think most people, because the filters stop it, emails goes. That is one reason some people use it as a shortcut. But most documents and conversation will have female genital mutilation.
Fatu, and then we'll move on to multi-agency approach, and my colleague John Mason has got a few questions to ask as well.
Okay, thank you. Just about the issue of terminology, I remember when I was writing my dissertation, if Una can witness this, I was very wary of using the term mutilation. I wasn't comfortable using the term mutilation. Until I finished my dissertation, I was using circumcision. I couldn't use the term mutilation on myself. And this is the problem that many women who have had FGM have with the term, because they don't see it as mutilation. So that now I can use the term mutilation anyway. I'm getting used to it. But I know many women don't like to use that term, and if you're speaking to them, if you use the term, they will find it very offensive. So, but there are ways. Sometimes you can explain this. Instead of saying, have you been mutilated, you can explain, I understand in certain parts in Africa, a woman goes through this procedure where they are cut, it's a tradition. You explain to them, then they will understand. But if you come and start asking them, have you been mutilated? No, because they don't see it as being mutilated. That's one thing. And again, going back to the NSPCC helpline, children are not going to phone to report this, because most children from practicing communities don't actually know FGM exists if they live here. So how would they know such thing is about to happen to them? So some of the things that they would say is that my parents are taking me home for a party or something, and this is what professionals are being encouraged to recognize, like what children would say, but most children won't talk about going to get caught or things like that. And another thing with the NSPCC helpline, the problem I have with it is that although it is set up and professionals working in that area know about it, but how many practicing community members know that this helpline exists? They're not being made aware of the helpline. We know, but community members don't know. And so what are the chances that one of them would report this incidents like that?
Thank you very much. Can I just correct what I says earlier? It's actually John Finney who's now going to ask some questions. Apologies.
No problem. Thank you, Convener. Convener, if I make a couple of comments. First, please, on issues that have been picked up. I was going to ask questions on the multi-agency approach, and I think some of that area has been covered. It was a point that Mukami said, and indeed the purpose of why you're here today, because it's very clear in our papers, and I hope it was to you, that this was to inform the remit for a potential inquiry. So I would be very interested, first and foremost, if you think there should be an inquiry, because there's none of the committee members would want to do anything other than be helpful to the situation rather than create difficulties around it. So I'd be interested in the issues of terminology that have been said. And also, you're all very welcome here, and I found your information fascinating, but it's inescapable that there are no male witnesses. And it would seem to me that, as things stand at the moment, in most communities, males have a predominant role. I think that's not always a great idea. And likewise, with regard to decision-making in the public sector, that's the case. So who should we be having here if we do go ahead with inquiry? And I imagine we will. And hear from, and what should we be asking them, would be my questions, please.
Amy, and then Jan. Hands are all up.
To go for your second point first, I think the involvement of men, I mean, it's a practice that is kept predominantly on the female side of the family, and the men largely aren't getting involved. I think what we touched on earlier, the reasons for doing it are often related to the man and pleasing the man, and so there's definitely a role there. But I think in terms of the nuts and bolts of how the practice is carried out, you are very much focusing on women, and the representation of women speakers today reflects that. I think if you send a male into the communities to talk about this, as we've touched on previously, because it's not because sex and sexual health is not widely discussed, I think you'll just come up against brick walls. There has been examples where faith leaders have been involved, which is useful, although have also been warned by people that have been doing that you need to be absolutely clear to the point that you're, because I had one woman that was doing some joint work with a faith leader and thought they were on the same page, and then right at the end of the talk he said, but you can do this and that's fine, and the trainer was just like, no, that's not fine. And so involving faith leaders is very important. Making sure you're on the same page is even more important.
Thank you. Jan?
I think it is very difficult to get men involved in any work on gender-based violence. I mean, we can barely get 5% males at a training day about domestic abuse, and we've been talking about domestic abuse for about 40 years. So I think you've got a long way to go, unless you bring in some sort of law making it compulsory, possibly. I think in relation to the inquiry, I thought the point, Nina could maybe say more about this, the point in the paper that the Refugee Council submitted made a lot of sense to me, which is that the government has just fairly recently commissioned various pieces of work, including looking at the data collection, and there's quite a lot of discussion ongoing. Most of that work hopefully will be completed towards the autumn, so to me it might make sense to wait a while and consider again when that work's completed.
Thank you. And Nina?
Yeah, I was just going to make that point actually. I think there are so many unknowns at the moment, and there has been quite a lot of investment recently in taking forward some work, whether that's data collection or looking at best practice approaches in other parts of the UK and Europe, some community engagement work that Women's Support Project has been funded for. So I would suggest that it might be more fruitful to look again at what's been produced by the summer and see if that sheds any further light on particular areas that the inquiry might like to focus on, or particular areas where perhaps we've been unable to get data that's not public or that's not available or not there. On the issue of men, I think definitely, as everyone else has said, it's really important to engage the whole community on this issue. But I think I'm not sure others may be aware of work that's been done with men on this issue. I'm not aware of any myself, but I think it would. You need to make sure that any witness is representing the views of the community rather than an individual view. You would run the risk, if there hasn't been any community development work done with men, you'd run the risk of getting individual views rather than a representative view of following some sort of community development engagement work.
Thank you. We've got Anila.
Yeah, I would echo that concern, Nina, to make sure it's not an individual person's viewpoint. But I would say engaging male members of the community is essential. And in terms of working on FGM, it's really at the starting point. We address a variety of different issues in the work that we do, including child abuse, other forms, sexual abuse, honour-based violence, forced marriage. And in the work that we've done, we found it essential to engage with male community members to create the change in cultural attitudes, and we've had to do it very sensitively, very quietly, often on a one-to-one basis with male members, meeting male members of the community, and it takes a long time. It's not something that can be done overnight, and it has to have that sensitive approach. So I think it's something that definitely needs to be done. And as I was saying earlier, though, just to try and pick up on a couple of the points, I'll be really quick. I think it would maybe inform the remit of a potential inquiry if we did have more baseline information, because that really is lacking in terms of FGM at the moment. And maybe it's something that we could revisit to look at to see what would be the benefit of the inquiry and what's it going to bring. But the key point for me would be holding statutory agencies to account to see if we do have guidelines and policies, why are they not being implemented? Because from the work that I'm doing with frontline professionals, there is a big lack of awareness on FGM, and there's not that implementation of guidance and policies. And we maybe need to look at what can be done to provide that sustainable support for community engagement programmes. I completely agree with what was said earlier by Alison. When I said the onus should be on professionals and staff, it's in terms of reporting, but of course we need to engage with community members on the issue. And we already run educational programmes with children and young people on all forms of child abuse, not stigmatising it to one community or just FGM. So yeah, there's a lot that I think could be done with an inquiry and definitely in the future, but it would be good to see the outcome of this information gathering over the summer.
Okay, thank you very much. We have Una and then Alison.
I mean, mine's just a quick point, but I think you were saying not just men from the communities, but also men from budget holders. And so following a bit what Nina said about Anina said about statutory agencies, I think it would be important to include people who are in management in these agencies that are not delivering, so it's holding to account. And also any inquiry on this issue would also be a kind of awareness-raising exercise, because there would be attention focused on it, and I think that would be an important thing to keep in mind.
Yeah, very briefly, I just wanted to... I obviously wasn't clear enough when I was talking about the NSPCC helpline, because it's aimed at adults, professionals and adults in the public to call and report concerns rather than children. Just your point, Fatu, about children not calling to report themselves. So understand that the barriers to that would just be so extreme. In saying that, Childline has had a very, very small number of calls, 22 to be sort of precise, in the last year. And these are obviously from the children who are a bit older and have developed a bit of understanding, possibly just because of the awareness raising that all your organisations have been doing over. And just lastly, to say that any inquiry, I agree with the points that have been made about the timing of the inquiry, definitely following the work of the Scottish Refugee Council, but also just the NSPCC, anything that we can do by way of analysing what comes into the FGM helpline as well as Childline on this issue to provide us written evidence to the inquiry, would be very, very happy to do.
Are you okay?
Yeah, for the avoidance of doubt, I was not being in any way disparaging to our witnesses, quite the reverse. I think it's been very helpful. Can I just ask one brief question, if anyone had any comments? There is a very well-established multi-agency approach adopted in relation to child protection issues. If this general issue was to be looked at that, are there lessons we can learn from child protection arrangements that are in place at the moment?
Anila, please.
Well, FGM is a child protection issue. It's clearly, and it should be dealt with.
But everything we're hearing saying it's not being picked up on that basis.
So it's about the implementation. So I don't think we need to create a new procedure or a new system. I think the current child protection arrangements are fine. It's about encouraging frontline staff and giving them the confidence to be able to tackle issues of FGM and follow the correct procedures that are already in place within their local authority. I think that's the key, and a lot of time it is building the confidence. Sometimes they have the knowledge base, but they have that fear. And you know, Makami said quite a lot of things today, which most of which I agree with, but I think sometimes when we're working with communities, we can err too much on the side of caution or sensitivity, and sometimes we need to just take a step or a stand and say, this is child abuse, this is a child protection issue. I don't mean to stigmatise a community, I don't mean to criminalise them, and yes, I want to have you on board, but at some point I have to say that I don't agree with this, and we need to take steps to try and stop it. So, Makami, I hope you kind of know where I'm coming from on that, but we found it very difficult to get any hard or fast information, concrete information on FGM, because people are afraid of being criminalised. We have legislation in place and potential prosecution, which is why we only get anecdotal evidence. I've heard that someone said this, that someone said that about someone else. So it is very difficult to piece the pieces together, but I have to be clear in the work that I do across the board when it comes to working with all minority ethnic communities that whatever the form of child abuse is, it isn't acceptable, and we can't use our culture as an excuse, or we can't say I'm being victimised, this is racism. We have to be really clear on that, I think.
Thank you very much. Makami.
Yeah, I think, thank you. Anila, I think you got me wrong. The people who know me around the table well know I don't take prisoners on this subject. And what I was trying to do is to encourage people to understand what the other side, what I'm coming across when I try to say that FGM is, there's no place for it in the 21st century Scotland. I'm really critical of organizations that wrap women in cotton wool and hide them and say nobody can speak to them, nobody can engage with them because they need to protect them. I don't think when it comes to child abuse or FGM or anything, we can actually protect the adults, no matter who they are. So I hope that has cleared your position, because quite clearly I would be really cross if anybody misunderstood that. But in terms of inquiry, I think the bottom line is what we want to find, what the end product of the inquiry is. And if it's going to happen, it is absolutely important that we have all stakeholders around involved in the inquiry. We need the police because ultimately, if persuasion, prevention doesn't work, we need to have people who are able to address the issue, especially if women feel they are not able to report and they don't feel protected enough. We need health professionals. We need education, because the children go to schools and then teachers can find a lot about what goes on. And we also need social services. But I think one thing I'm really concerned is, most of the time when I speak to professionals, they tell me that they are on a steep learning curve. And we can't wait until all professionals are trained before we say that we're going to do work on prevention. So we must have a look at what is it now. The inquiry must look at what is it that stops professionals use the existing guidelines, like on child protection. I know many people have said it's not in a case of numbers. There are not enough numbers, but I always tell them it's not a matter of numbers, it's a matter of need, and one child is one too many. So I think when we're clear about what the end result of the inquiry would be, or what area we're going to do, you're planning to do, then it would be easier to input and suggest other people who could be involved in it. But definitely, faith leaders have to be involved, because one of the things, people from practicing communities also have this profound faith and they really listen to the leaders. And in countries where this has gone down, is because one of the women in Kurdistan said that she was one of the people who used to mutilate girls, But now she has television, and she has watched and she's heard Imam saying it's not in the Quran, so she's not going to do it anymore. It's not a religious requirement. So if they condemn it, then you'll find more and more women will feel empowered to say no, because they may say no to the family, but they may not want to say no to God. So looking at other people who could have an impact on this would be very good.
Can I pass you over to John again?
Yeah, I wonder if that's been touched on by a few of the speakers, but if you could maybe detail what's happening elsewhere in the UK and in Europe, and what we in Scotland could learn from that, because we're very keen. We've heard examples of good practice. But.
Good. Yes, Nina.
I'm not sure I'm in a position yet to detail what the best practice is and what's happening in other parts of the UK and Europe, but we'd certainly hope to look at that as part of the scoping project, and to carry out a few interviews with people that have done some really successful work in this area. The European Institute of Gender Equality report is a kind of starting point as it draws together some work that's been done. One example would be work of organisations such as Forward and Equality Now, down in England in particular, and also the Rosa Fund for Women and Girls has been carrying out a special initiative around FGM and small bits of funding for community awareness and peer research and peer engagement work in, I think, mainly in England. So those are a few examples, but I think some of the best work has been work that's drawn together all the different aspects that we've been talking about today. So community engagement is key, training for frontline professionals, obviously the having a framework, a legislative framework in prosecutions is important, but it needs to be combined with all the other elements of prevention and service provision as well. So you know, the best examples are ones that combine all of those together.
Two, please.
Yeah. One of the things that I gathered from doing my research in the area of health is in England what they do when a woman is pregnant through that monitoring system. I think it would be good if Scotland copies that as well. I know England and Wales both do it. When a woman is pregnant, they get this information and it's recorded and it's also passed on. Another problem we have in Scotland is to know the referral. Who do you refer? If you find out about an incident, who do you refer it to? Is it the police? People are not very clear about that as well. We've had a lot of organisations ask about that. What do? We need to have a clear referral structure as well.
Okay, thank you. And finally, Una.
Two things. One, I think we could also learn from countries outside Europe where there's some excellent work being done. And it struck me, as I've been sitting here today, that a lot of my main work is in HIV, and actually in Scotland there's some excellent practice with very similar issues where I've had to engage particularly with African communities around the issue of HIV. So there's a Lothian strategy group I sit on, which is about doing training with GPs in Lothian around cultural competency. So I think there could be some profitable learning possibly for some other areas.
Thank you. Do any of my other colleagues have any questions we'd like to ask any of our witnesses? No. Can I then just say thank you to all the witnesses that came along today and for being so open and honest in the information that you've actually given us. We can't thank you enough for that. And that actually concludes today's meeting. Our next meeting will take place on Tuesday, the 20th of February. Thursday. I apologise, John. Thursday, the 20th of February, and will include oral evidence from the advisory group on tackling sectarianism. And that's the meeting closed. Thank you.